Hi everyone, welcome back to my YouTube channel, and today we are going to talk about 8 changes in dentin. So let's start our topic with introduction. Dentin is vital lining mineralized tissue that forms the bulk of tooth structure and protects the dental pulp. Unlike enamel, dentin remains physiologically active throughout the life due to continuous deposition of odontoblasts. Because of this, dentin undergoes significant age-related changes that affect its sensitivity, strength, caries susceptibility, and clinical treatment outcomes. Understanding these changes is essential for restorative dentistry, endodontics, and geriatric dental care. Structure and composition of dentin. Composition: it has mineral content, organic matrix, and water. Mineral content is 70%, that is mainly hydroxyapatite crystal. Organic matrix is 20%, that is predominantly type 1 collagen along with non-collagenous protein such as dentin phosphoprotein and dentin sialoprotein. Water is 10% in dentin, that is present within the tubules and matrix. Structural organization. Dentin is tubular in nature with dentinal tubules extending from the pulp to the dentino-enamel junction. Intertubular and peritubular dentin provide strength and elasticity. Odontoblast processes extend into the tubules, maintaining dentin vitality. Types of dentin relevant to aging: primary dentin, secondary dentin, and tertiary dentin. Primary dentin is formed during tooth development until root completion. Secondary dentin is deposited after root formation and continues throughout the life, contributing significantly to age-related changes. Tertiary dentin is formed in response to stimulus such as caries, abrasion, erosion, or trauma, not always age-related but commonly seen in older individuals due to cumulative exposure. Age-related changes in dentin. Dentin undergo extensive changes with aging that affect its structure, function, and appearance. These changes include structure and morphological changes, dentinal tubule changes, histological changes, physical and mechanical property changes, functional changes, and changes in color and appearance. Age-related changes in dentin. First are structural and morphological changes. There is increased secondary dentin deposition as secondary dentin is deposited gradually on the walls of pulp chamber and root canals. It leads to reduction in pulp chamber size and narrowing of root canals. Pulp arms become less prominent. Second change is formation of tertiary dentin, that is over time with microtrauma and mild irritants that stimulate tertiary dentin formation. It results in irregular dentin with fewer and more disorganized tubules. Third change is peritubular dentin thickening, that is, peritubular dentin continues to deposit throughout life, narrowing the tubules, thus contributing to occlusion or complete obliteration of dentinal tubules. Second age-related change is dentinal tubule changes. First, there is tubule narrowing, that is, aging reduced tubular diameter due to peritubular dentin deposition. It leads to decreased dentin permeability. Second tubule changes is dentinal sclerosis, as tubules become completely mineralized, creating areas of transparent dentin. It is common in root and deep dental layers. It reduces sensitivity and microbial penetration but increased brittleness. Third tubule change is reduction in tubular density. That is because of loss of odontoblast process and mineral deposition that may reduce the function number of tubules. Then there are histological changes that include decreased water content, altered collagen cross-linking, and reduction in odontoblast activity. Decreased water content. Aging dentin contains less intertubular fluid that results in harder, more brittle dentin. Altered collagen cross-linking. Collagen fiber become highly cross-linked, reducing elasticity that make dentin more prone to cracking under stress. Reduction in odontoblast activity. Odontoblasts show degenerative changes with age that lead to slower dentin deposition and altered structural organization. Physical and mechanical property changes include increased hardness and brittleness, reduced elasticity, and decreased permeability. Increased hardness and brittleness. Sclerotic dentin is harder but less flexible, and it is more prone to fracture during restorative procedure. Reduced elasticity, that is loss of collagen resilience, decreased shock absorption capacity. Decreased permeability, that is due to tubule narrowing and sclerosis. It limits dentinal fluid movement, reducing sensitivity. Functional changes include decreased tooth sensitivity, decreased caries progression speed, and altered pulp dentine complex response. Decreased tooth sensitivity. Closure of tubules restrict fluid movement, reducing response to stimuli. Older individuals often report less thermal or tactile sensitivity. Reduced caries progression speed. Sclerotic dentine is more mineralized and resistant to acid penetration. However, once inspected, it is more difficult to manage due to hardness and brittleness. Altered pulp dentine complex response. With reduced cellular activity and decreased vascularity in pulp, reparative responses become less robust. Then there are changes in color and appearance that can lead to darkened dentine and increased opacity. Darkened dentine. Increased pigmentation and sclerosis lead to darker and more yellowish teeth. Secondary dentine thickness reduces enamel translucency. Increased opacity. Sclerotic dentine exhibit a glossy or translucent appearance in deeper areas. Clinical implication of age-related changes. First are endodontic consideration, narrow canals and pulp chamber obliteration, complete root canal treatment. Complicate. Locating canal opening becomes significantly more challenging and sclerotic dentine require modified instrumentation technique. Second clinical implication is restorative consideration, as harder and more brittle dentine increase the risk of microfracture during cavity preparation, and bonding efficiency decrease because reduced permeability and it affects penetration of bonding agents. Third clinical implication is prosthodontic implication, as altered dentine elasticity affects tooth preparation and retention form. This reduced sensitivity allows deeper tooth preparation but also risks pulpal damage. Fourth implication is caries diagnosis, as sclerotic dentine may mask caries clinically. Caries progress more slowly but can be more difficult to treat due to hardness. Fifth clinical implication is periodontal consideration, as exposure of sclerotic root dentine is recession areas may reduce sensitivity but increase susceptibility to root caries. Conclusion of this lecture video. Dentine undergo profound age-related changes affecting its structure, composition, and function. The deposition of secondary and tertiary dentine, tubule sclerosis, reduction in pulp chamber size, and increased mineralization fundamentally alter the mechanical and biological behavior of the tooth. These changes reduce sensitivity and increase resistance to caries, but also introduce challenges in restorative and endodontic treatments. Understanding these transformations is essential for effective management of the aging dentition and delivering optimal dental care to elderly patients. And this was all about age changes in dentine. Hopefully you liked the video. If you do, don't forget to like, share, subscribe and comment. Thank you for watching.